SABC News, independent, impartial.
As we commemorate World Haemophilia Day, is enough being done to create awareness about the condition? Globally, 1 in 1,000 people has a bleeding disorder. Most are not diagnosed and do not receive treatment. Hemophilia treatment comes at a huge cost. Hole says not enough is being done to raise awareness about the condition.
There are organizations that are doing the best, they're doing the most to help people with hemophilia, but I think government is failing.
I wish there could be a bit more awareness like they do overseas.
Globally, 1 in 1,000 people has a bleeding disorder. Most are not diagnosed and do not receive treatment.
It looked like we almost abused our baby. He was full of blue marks everywhere where we picked him up.
If maybe I'll do something hard or I'll hit something, like my joints would swell.
They did all the tests for hemophilia, and then they called us in to say that he is diagnosed with less than 1% of factor 8 in his blood.
Most people are clueless about it, and it affects us, people with hemophilia.
So hemophilia is a rare inherited genetic bleeding disorder. Now, the worldwide incidence of hemophilia is not well known, but sufferers are estimated at more than 400,000. In South Africa, 1 in 5,000 boys are born with hemophilia. Now, it affects people of all races and ethnic origins globally. Regrettably, a vast number of patients with hemophilia or other bleeding disorders remain undiagnosed or are diagnosed at a very late stage. Unfortunately, approximately 75% of people with hemophilia around the world still receive inadequate treatment or have no access to treatment at all. World Haemophilia Day is recognized worldwide and celebrated on the 17th of April to increase awareness on hemophilia and other inherited bleeding disorders. The theme for 2019 is Reaching Out, Connect to Your Community. So today we discuss hemophilia, and we'll be joined in studio by a clinical hematologist based at Charlotte Maxeke Johannesburg Academic Hospital, an administrator from the South African Haemophilia Foundation, a mother of a child and an adult living with hemophilia, who will share their story with us on what the impact is on family and social life. So be part of the show by asking the panel some questions or simply just sharing your views with us. The number to call is 011 714 5861 or 5877. You can also tweet us at SABC Health Talk or simply interact with us on our Facebook page, SABC Health Talk. So sit back, relax, and learn from this bumper show coming to you just after a short break. I'm Dr. Sello Mataung, and this is Health Talk.
Okay, stop. Times have changed. You want to be someone? Be you, the person behind the filter. You're unique. Nothing added, nothing artificial. And you deserve a juice that's 100% fruit. No added sugar, no preservatives. Maybe a fruit juice can't change the world, but it can refresh the way you see it. Because in a world filled with fake, nothing's more precious than real.
You do it like that, I do it like this. You do savory, I do it sweet. You do it, I do it, and what do they say? We love it all. Sasco, taste the care.
We do not just speak, we let every voice in our nation find full expression in language and in culture. We do not just teach, we empower all people with education. We do not just bring you the news, we place you where the news is happening. We do not just entertain, we take you on journeys. We do not just broadcast sport, we create an arena for sporting heroes to inspire you. Ours is not just a job, it's a calling to ensure that everyone in our nation is informed, educated, and entertained. We're able to do this because you do your part. SABC TV licenses. It's all made possible by you.
Kgomoto Gole from Atteridgeville in Tshwane couldn't believe the news brought by a minor injury when he was only 3 years old.
When I was growing up, I actually beat my tongue and I bled, and then my mom took me to provincial hospital, and then they couldn't help me. Then from there, we went to Joburg General. Then that's where they discovered I was hemophiliac.
As a young boy, Gole says hemophilia prevented him from living his life to the fullest.
It was hard for me to take part in sport because if maybe I would do something hard or I would hit something, my joints would swell, so it was hard for me to take part in sport. It was so hard.
Gole, who works and studies, continues to face challenges because of hemophilia.
Academically, it affects me because I can't go to school like normal people. I miss classes at work. I have sometimes I can't even spend 5 days in a week going to work because sometimes you get a bleed and I would have to go see a doctor. Financially, sometimes I don't have enough money, but you have to make a plan instead.
Accessing treatment for Gole, who is based in Tshwane, has seen him traveling long distances at high costs.
I prefer Short Matleke, and they support you, the support there, it's much better. Even people there, they understand the condition. You don't have to explain yourself. They know you're coming. You don't have to go to pharmacy. They do that for you.
Gole says not enough is being done to raise awareness about the condition.
There are organizations that are doing the best, they're doing the most to help people with hemophilia, but I think government is failing, it's failing us, people with hemophilia, because sometimes you go to hospitals, you go to casualties, they don't know nothing about hemophilia, you understand? So you have to explain what is hemophilia before you can get help, you understand? Those are the challenges that we're facing.
All right, so to learn more about this, it's a great pleasure to welcome our special guest for today. First up is Professor Johnny Mahlangu, who's a clinical hematologist based at Charlotte Matlake Johannesburg Academic Hospital. Now, he's got a long, illustrious CV, and we can't get through everything, but he's also head of the School of Pathology at Wits University. Welcome to Health Talk, Prof.
Thank you, Dr. Mugwan.
All right, and of course, we have with him Julie Malan, who's the administrator from the South African Haemophilia Foundation. Welcome to Health Talk, Julie.
Thank you so much.
All right, Prof, let's start with you. Not too many people know about this condition. What is hemophilia?
Well, it's not a common condition. It is an inherited bleeding disorder in which a person is born lacking one of the clotting factors, a protein in the body that participate in the formation of the clot.
Right.
So if one were to look at the prevalence of the condition, we are talking about 1 in 5,000 boys who are born with hemophilia, hemophilia A, or 1 in 25,000 boys who are born with hemophilia B. And the commonest way it presents is through bleeding into joints, but the individuals can bleed into any tissue.
Right.
They can bleed into the skin, they can bleed into the gums. So bleeding is actually the very big symptom that one needs to look out for in the diagnosis of hemophilia.
All right, we're going to come back to that, the clinical features and all, but let's just bring you in here, Julie. There's the issue around awareness, and we heard that the government is not doing enough to raise awareness and so on. How much do people know about hemophilia? I mean, you running the foundation, perhaps you can start by telling us what the foundation is and what you do.
So the South African Haemophilia Foundation is basically a non-profit organization that is there to support people living with hemophilia as well as their family and friends. It's a place where we bring people with the same disease together, where we get support from each other. We try and support the people in any way we can within our financial means, even if it means just helping a person get from his home out there in a rural area to a treatment centre. We're also involved with the committee of scientific people where we try and establish treatment centres all over South Africa, which we have done with quite good success, where we have about 21 treatment centres all over South Africa. So with regard to raising awareness, the 17th of April is always a big day for us, where we are very happy to see you wearing your red bow tie.
Right, so we're painting the SABC red, all of us are wearing red.
Yes.
Just tell us about that. What does that mean?
Yes, so we've got what we call the red tie campaign, where we'd like people to, on the 17th of April, wear their red ties, the red scarves, so that people can ask us, why are we wearing this? And we can start educating people about haemophilia.
Right.
Because there's definitely a lack of awareness. And the way in which we see it is the fact that Prof has given you what we expect for people, what the live births is, 1 in 5,000. We've got about 2,300 patients on our registers. If we take a population over 50 million people, we should actually have more than 5,000 patients on our books.
All right. So back to what you said earlier, Prof, that it affects 1 in 5,000 boys. Why should it be boys only? Is it a condition that affects only boys?
It is a condition that has a pattern of inheritance called X-linked. By that we mean the mutation for hemophilia is carried in the X gene. As you know, females have got 2 X chromosomes and males have got 1 X chromosome and a Y. And it is in that context that in fact if a female is carrying the hemophilia gene in the X chromosome, they will be able to pass it on only to boys and not to girls, in the sense that if the girl does have carry the hemophilia gene and marries a male who's normal, we expect the boys to be sufferers. On the other hand, if you've got a male who carries a hemophilia gene, in other words part of the XY, the X is carrying the gene, they will pass it to all the girls, but the girls will be carriers. They will not be hemophilia sufferers, whereas the boys will not be affected at all.
Right.
It is a bit of a complicated genetic analysis, but that's the reason why it predominantly affects boys rather than girls. Girls are carriers and boys are affected. Having said that, there is a handful, and it's not a large number, of females with bleeding symptoms who are carriers, but it's very rare.
Right.
Yeah.
Right. Okay, so then let's get back to diagnosis then. At what point do parents normally, become aware that there's a problem? And how is this condition diagnosed?
It depends on the level of the clotting factor which the individual has. We, for convenience, classify hemophilia into 3 categories: severe, moderate and mild. If you have a severe phenotype, in other words your factor level is less than 1%, you bleed spontaneously and you can present any time during your life. You can present at birth, you can present whilst the baby is starting to walk. Sometimes in fact they present a little bit older, depending obviously on their physical activity. If it is someone who's got a mild or moderate phenotype, they often will only present upon what we call hemostatic challenge, when they are injured or when they undergo surgery. So you might not pick it up at all for someone with a level that is not normal, but is actually not less than 1%.
Right.
So only when they go to a dentist or they've got an appendix removed, it's only then when it is picked up. So when the individual presents will depend on the level of the factor they have. By and large, the majority of our patients, close to 80%, have actually got less than 1%. So predominantly they will present quite early in life, and by early in life we mean at the time of when they are born, the umbilical cord might actually just bleed a little bit more than usual, and then they might have intracranial bleed if they've had a traumatic birth, and of course as babies grow and start to explore, when they fall they will start to have bruises, just not different from what you saw earlier on when the mom was describing the baby who might look like an abused baby, but actually the baby's got an underlying bleeding diathesis.
Okay. From a foundation's perspective, I mean, we heard that obviously the sufferers would be boys. What sort of ages, racial mix, that sort of thing? What's your experience there in terms of your register? Do you keep a register at all?
Yes, we try to keep a register.
Right.
So yes, as Prof said, it affects all races. So just looking at the population of South Africa, the majority of our patients are African patients. We've got a wide range. We tend to see more and more people, I think, as awareness increases and babies are diagnosed earlier. We've had quite a number of new babies diagnosed this year already. And nowadays, with Google being active and everything, the internet, we get more people contacting us via our website, via our Facebook page, and all of those people we get into contact with. We've got a patient pack that we then deliver to the patients. One of our mothers will then contact them, perhaps go and visit them. And then we've got outreach nurses that goes out also to go and give support. Because parents of a new baby who was newly diagnosed really need a lot of support. And actually the best support is from someone who's been in a similar situation than you are at that moment. So that's how we go about to just get to those patients and how we try to help them.
All right. Prof, I want to ask you about, the prognosis. Is it curable? Is it treatable? But we're going to keep that for after the break. Okay. For now, time for a quick break. When we come back, we'll continue our discussions on hemophilia. Please stay with us.
The SABC News mobile app is your one-stop digital portal to all the news you need. Stay connected with the latest in breaking news. Watch the SABC News channel along with clips and live streams of all the big news events. And listen to all the SABC News radio stations live, including podcasts and much more. Simply download the SABC News app to your Android or iOS device from either the Play Store or the App Store. SABC News, independent, impartial.
The Zimbabwean government says it's now planning to give compensation to white farmers who were forced off the land they occupied by the government of Robert Mugabe.
For reasons of political expedience, this attempt is driven by opportunism and is bound to further deepen the political and economic crisis in Zimbabwe.
A small group of people chanted Makashule's name at the launch in Sandton City. They allegedly ripped apart some copies of the book and threw the pages around.
Clearly that book wants to divide South Africans.
We wanted to make it very clear that we stand by this book and we stand by Peter Louis Myburgh as an outstanding author.
Africa, home to the fastest growing youth population.
The African kid goes through similar problems. It doesn't matter where in Africa you are.
It is predicted that by 2030, the number of young people on the continent will increase by 42%.
But so much good lies in the different political parties that they can put it together and create a South Africa we have never seen before.
But are they interested in the politics of their countries?
As a conscious citizen, I have to make my mark.
They all make promises, so I don't know which party will deliver on their promises.
Watch African Perspective on Wednesday at 9:30 p.m. Central African Time on SABC News.
Welcome back. We're discussing hemophilia with our guest, Professor Johnny Mahlangu, clinical hematologist based at Charlotte Maxeke Johannesburg Academic Hospital, and of course Judy Malan from the South African Haemophilia Foundation. So we were just before the break talking about this condition, hemophilia. I mean, we've described the clinical features and all. What does it mean to be diagnosed with hemophilia? Is it a curable condition?
It is definitely at this day and age, we are in transition. Up to now, it has been a very manageable condition and not curable. And we are transitioning now with the new therapies called gene therapy into a potentially curable condition.
Mm-hmm. So perhaps let's start now talking about the principles of treatment. You mentioned the factor 8 issue and so on. What are the principles of treatment in these patients?
So the approach is actually a very simple approach. For someone who has got a diagnosis already made, you can be reactive to the treatment or you can be proactive. By reactive, we mean that you wait until they bleed and then you replace the missing factor. By being proactive is giving someone the missing factor before they bleed in order to prevent them from bleeding. Those are the two cores of our approach to hemophilia care. Globally, the movement is now moving away from being reactive to being proactive. So the global accepted standard of care is actually prophylaxis. And by prophylaxis is we have a schedule of replacing the missing factor on a regular basis. And we find that if you raise the level of factor to a particular level above 0, you prevent bleeds. In fact, you also allow the individual to have a normal life, to be able to live a normal life like any other person without hemophilia. Okay. So those are the two important principles. Perhaps the second set of principles, which is also in an evolutionary path, is we accept that you have to replace the missing factor, which is important. We are now evolving into not replacing the missing factor, but manipulating the clotting system without replacing the missing factor. And perhaps later on we can talk about some of the exciting developments there. So we could actually leave the missing factor alone and manipulate the clotting system, the so-called non-replacement therapy, allowing the individual to form the clot that they can't form in their own nature. And in fact, achieve the same outcome, which is preventing bleeds.
Very interesting. Julie, we said well, do we know what the causes are or the risk factors for hemophilia? We've just heard about the genetics, situation. And in fact, my question to you is around how you deal with, parents that come to you with all of these questions to say, so what does it mean now? If I'm told that, my mom is a carrier, am I going to have, hemophilia later on in life? What sort of counseling do you see yourself getting involved in around that?
Yes. As was said previously, it is an inherited genetic condition. And about 70% of cases, there is a family history of hemophilia in the family.
Right.
And what we have at our treatment centres, we actually have a multidisciplinary team. Right. So we don't only have pediatricians or hematologists, but we also try and have people like genetic counsellors there. We can sit down with the parents and explain the inheritance pattern, which is very important. Because if it is the first time that the parents, it's a first baby in the family, then it's important for parents who want to have a second child to know there are risk factors with regards to the second one. Right. So that's the way in which the foundation supports basically making sure that the treatment centres has got the personnel to be able to do that for the patients. And then about 30% of cases are actually mothers or children who's born with a new mutation. So no family history, a spontaneous mutation happened, and then genetic testing can also be offered to try and determine. Very often parents then want to know, well, it's a new mutation, was it me, the mom, or was it in my son, for them to make future planning with regards to family.
Interesting. Then there's this concept of acquired hemophilia. Can you just take us through that and what exactly causes acquired hemophilia?
Yeah, that's a very, very important distinction to make, comparing that to genetic or congenital hemophilia. It is a scenario in acquired hemophilia, it's a scenario where your own immune system start to recognize your own proteins as foreign. In acquired hemophilia, you develop antibodies against your factor 8 or your factor 9. The management of an acquired hemophilia, the presentation is not different from someone with hemophilia. Right. They present with extensive bleeding, and often it's not at birth, it's sometime during their lifetime, and it is usually associated with other events. Someone may well undergo surgery, and then suddenly the body sees their factor VIII as foreign and develop antibodies against that.
Okay.
So the presentation is more or less the same, but the treatment of acquired hemophilia requires us to use different therapeutic approach. We use what we call bypassing agent, and the reason for that is you've got factor VIII, which is obviously bound to an antibody that the body produces. So every time you replace that factor VIII, as you would do in congenital hemophilia, the antibody will simply bind to it and it will be ineffective. So we give other treatment called bypassing agent that will bypass that effect of binding to factor VIII and then allow hemostasis to happen.
All right. Let's take a call on the line. We have Masabulelo from Johannesburg. Masabulelo, welcome to Health Talk. Masabulelo, are you there? Okay, we seem to have lost her. We'll get back to her. But just around that, the causes now that you mentioned that forming antibiotics. Any triggers that we know about?
For acquired hemophilia, we've identified a large number of triggers. Surgical interventions is one, and it would seem that in fact certain autoimmune conditions are associated with acquired hemophilia. We do know that it's often associated with vaccination sometimes, being exposed to particular antigens. A large number of our patients, in fact, may well be the first sign of the development of a cancer of some sort. There's a fair number of associations that we have identified. I mean, of course, associations are slightly different from proving the causality. We do know that when the acquired hemophilia is present, certain conditions are also present. But proving that, in fact, those conditions are the reason why the body has decided not to recognize its own proteins, it's a little bit something that we're working on at the moment.
Okay. Just so that we don't create confusion and raise anxiety levels amongst our viewers. Children normally play around and they bleed. Some of them will have nosebleeds and so on. I'm sure that sort of thing comes to you sometimes, with people saying, no, but my child has nosebleeds every other day. Could it be hemophilia? How do you respond to that?
Yes, we often get that, and I think the standard answer would be take your child into the doctor and let them have a look, because yes, a lot of people have nosebleeds, but usually with hemophilia you might have more than nosebleeds, you might see more symptoms, and then
all right. I believe our caller is back on the line. Masabulelo, welcome to Health Talk. Aheme.
Stokolo sa ka 11 years ago.
Right.
Has 11 years. Age of 3 years. Kya se se tswa mokola every time a hanta ke. O tswa mokola.
Right.
Ke ipotse hore na ke eng.
Okay. O mo iseng again.
Ke iseng ke ola ba robala di peteleng tsa di clinic.
Right.
Ba mo fa dipidisi.
All right.
Dipidisi tseo ha di mo thusi ke batla ho tseba hore na ha e tsale emkala le 3 years.
Right. Okay.
Yeah, the doctor didn't play no now. What's wrong, Kamwana?
Okay.
I'm not going to know. Woman take it to the holiday.
Yeah.
All
right. Okay. All right. Thank you so much for your question. And I think it's almost like she guessed, or I guessed exactly what sort of question she's going to be coming with. She's got a grandchild, for the sake of everybody else, who bleeds on a regular, his nose bleeds every time the grandchild comes to visit. The child has a nosebleed, and she's obviously worried, having listened to this, wants to know what's wrong with the child, because she's been to the doctor and they were given some medication, but this does not seem to be helping. Perhaps let's give that to you, Prof.
Thank you. Dumela mme. Re tla kopela gore o mtlisa ko spetlela ne re tlo bona gore bothata bokae. The most likely scenario is that it's one of three things. Either there is a local reason for it, in other words a blood vessel in the nose, or there is a coagulation protein such as hemophilia, or there is a platelet abnormality. And in fact we can easily find out. We do tests that will be able to tell us exactly which one is the cause. If it is hemophilia, as we discussed earlier on, we can manage that. If it is a local cause, We've got our colleagues who are called ear, nose and throat specialists who will be able to take care of it.
Okay,
Yeah.
so there's the message, Hemme. You take the child to the hospital so that, tests can be done to determine exactly what the problem is. All right, time for another quick break. When we come back, we talk to real people suffering from this condition. Please stay with us.
We do not just speak. We let every voice in our nation find full expression in language and in culture. We do not just teach. We empower all people with education. We do not just bring you the news. We place you where the news is happening. We do not just entertain. We take you on journeys. We do not just broadcast sport. We create an arena for sporting heroes to inspire you. Ours is not just a job, it's a calling to ensure that everyone in our nation is informed, educated, and entertained. We're able to do this because you do your part. SABC TV licenses. It's all made possible by you.
A few months after the birth of their son Duncan, Velin Rousseau and Charles McMenamin from Tshwane, who were first-time parents, noticed something strange happening in his body.
He was full of blue marks everywhere where we picked him up. And we first thought maybe we are picking him up too hard because we were also first-time parents. So it was very strange for us seeing these blue marks.
After several tests were conducted, doctors discovered that Duncan had hemophilia. His parents were told that he has less than 1% of factor 8 in his blood.
They didn't even know what factor 8 is at that time.
Duncan began treatment immediately, and his parents took it upon themselves to learn more about hemophilia. Trips to the hospital have become shorter as his parents are now giving Duncan treatment at home 3 times a week.
But it wasn't this easy in the beginning.
That's true.
And in the beginning you're not confident in doing it. So it is very hard doing it until you get used to it.
They also took it upon themselves to educate their son's school about hemophilia, as some injuries could pose danger.
Yeah. Head trauma is quite a dangerous thing for him because the symptoms of a hematoma can only show up after 4 days, and then you realize that you have a bleed in the brain, and that's one of our biggest fears is getting a brain bleed, because you don't know when it's happened, and just only after 4 days, and that then there's quite a lot of damage that could have been done.
Like many, Duncan's parents say that hemophilia treatment comes at a huge cost.
The factor is about 12,000 rand a month, and he uses it 3 times a week. That is only the factor. That is not the needles, the specified needles we need to use, or the citraflow we have to use to make sure it doesn't get infected, because he has a porter catch. That is a device that helps us infuse him at home.
As we commemorate World Hemophilia Day, is enough being done to create awareness about the condition?
I wish there could be a bit more awareness like they do overseas, but yeah, I would say there's not a lot of support from other institutions except for the foundation.
All right, so we're going to learn more about, the challenges and joys of bringing up a child with hemophilia. We still have with us Professor Johnny Mahlangu, clinical hematologist based at Charlotte Matlake Johannesburg Academic Hospital, and Julie Malan, who's the administrator from the South African Haemophilia Foundation. And we're now joined by Erica Bradley. Erica is mother of a child who lives with haemophilia. Welcome to Health Talk.
Thank you.
Erica. Okay. Just by the way, we do know that Julie also is a mother of a child with haemophilia, and both of them are going to share their experiences with us. So perhaps before we speak to them, just in terms of obviously the balance, if I can call it that, between the number of patients with haemophilia, children versus adults. Do we see more children versus adults? What's the split?
Because we are in a phase of identifying individuals, currently we've got more adults than children. But I mean, that is not unusual. In fact, it's a global phenomenon where most of the people are beginning to live longer, and therefore they tend to be the predominant population of adult in the population that we look after. There is still a small number of pediatric patients that are diagnosed, newly diagnosed on an annual basis. But if you took the total population that we have in South Africa, it's predominantly adults that we look after.
Okay. Erica, let's start with you. Please tell us your story about your child. I believe you have a 13-year-old child, is it 13?
Yes, yeah.
Please tell us about that.
Well, we, like the insert, also first-time parents with him, and at about 6 months we noticed these lumpy bruises on his body, and I was the only caregiver and I knew I wasn't abusing him, so I was a bit concerned as to why he was getting lumpy bruises. And when I contacted my pediatrician, he suggested I go for some blood tests, and he suspected either leukemia or haemophilia. And in our case it was the haemophilia, and after which we were then sent for treatment.
So how old was he when you were diagnosed?
6 months.
6 months. All right, okay. So we have another caller on the line. I just didn't get the name. Hello and welcome to Health Talk. Ruan. Are you there, Mpuan?
Yes.
Yeah, please.
No, Buang like talk.
Buang, okay. My apologies.
How are you?
We're good. How are you, Buang?
No, we are also good.
Yeah.
I'm happy to be at home and checking this because this hemophilia, I'm suffering from hemophilia now as we speak.
Right.
I went to the doctors. What is happening? You are losing blood, and the doctors can't find out why can't they see. Sometimes they send you to different places.
Right.
And you don't find out because it's hemophilia. We start on saying that you must see blood coming out.
Yeah.
But now the doctors, what they do, you lose blood, and you must remember I'm now 60. When you lost blood, it's not for the first time. It's every 10 years it comes. Like now, I'm out of doctors professionally. And then what is happening, you go to your doctor. Your normal doctor, my doctor is saying, when he checks, he says, no, but you don't have blood. What's going wrong? Because you've been suffering from high blood. But now, in this present moment, you don't have blood. And then when they sent me to the hospital.
Yeah.
When I went to the hospital, they said, no, you are losing blood at all. And then they call the people because they had to take me to the hospital for 2 weeks.
Yeah.
And then they pump into me blood.
All right. Okay. Buang, thank you so much for sharing that story with us, because I think that's another typical way of presentation. You agree with that, Prof?
Yes, I do, Dr. Mutaung. It is a pity that Buang has not yet been referred to one of the many treatment centers we have in the country, because all of his current frustrations and fears to some extent will be allayed once he has contact with some of us who understand the condition. And my advice would be let him come and visit one of the 21 treatment centers in the country, and we will certainly set his mind at rest with regard not just to the diagnosis but also to how we manage the condition.
Okay, all right. We'll get back to in terms of which other centers around the country do we have other than just Charlotte Macleay. Okay, let's get back to Erica. So 6 months old child gets diagnosed with hemophilia. Take us through.
Stress levels very high for the parents. Also not really, the only knowledge I had of haemophilia was a book I'd read by Bryce Courtney called April Fool's Day, because his son had haemophilia, and it's quite, obviously his son was a few years prior and the treatment wasn't as good as what it was today. So of course I had all these horror stories from that book in my mind when we heard the diagnosis. But obviously the Charlotte Macleay has been fantastic with or teaching us how to treat our child. In the beginning it was tough because when he bleeds and he was a toddler or a baby, he couldn't talk, so you only realized the bleed quite late, either through him not using a limb, an ankle or a shoulder or an arm. You only realize it quite late before you get treatment. Obviously, as he's got older now, he can say, Mom, I think I have a bleed in my knee or in my joint, and treatment can happen a little bit earlier.
And Julie, how about, social interaction at that age? I mean, how do these kids take the fact that they have this condition and they need to be careful around how they play and who they play with and that sort of thing?
Yes, what's interesting is, our children also, my son went through a phase where he's realized that every time if he told me he had pain or he had a sore limb or something, I would take him to hospital to give him factor, which he didn't like. So he went through a phase where he would hide that he's got a bleed until we get to a phase where we need to give factor for more than 1 day. And then finally they make that switch where they realize, but if I tell my mom quickly, I get treatment and it might just be a once-off and the pain is less. Then with regards to, we always used to tell him he can play and everything. There's just certain things that, he must be careful about. So from a young age he had the medical alert, for example, and when he went to primary school, he used to tell the kids if they asked him what was around his arm, that was to inform them that he is allergic to getting hurt. But he's adapted very well with regard to what they can do, because there's that belief they can't do anything, which is actually the opposite. We keep them away from contact sports, but we want them active, because if they're active, it actually strengthens their joints because it strengthens the muscles. So we went out from the idea that he's first a boy and then he's got hemophilia. And because of us being open about it, he's also become a person that is not scared to talk about his hemophilia, and he's not scared that his mates knows about it.
How old is he now?
He's also 13 actually
13.
now, yes.
Okay, all right. And where is he now? I mean, in the hemophilia journey?
My son?
Yes.
Our current challenge is we getting him to inject himself. He had a terrible phobia of needles when he was younger, because the same story that he didn't want to have an injection, and it got quite rough to the point where we were having to hold him down and hold him still and lie on top of him in order for him to sit still for us to inject him. And so it was quite traumatic for the whole family, for the siblings, for all of us. He would miss a day of school, we would miss our day's work, and inevitably end up all in tears. And so it was quite traumatic in the beginning. So he doesn't like needles, so it's been quite a journey for him to learn to inject himself. To actually hurt himself is quite a challenge, and that's where we are at the moment. He's learning to inject himself. This morning, actually, just prior to coming here, he did it before school, and it didn't work the first time, and then he had a bit of a meltdown because now it didn't work, and he had to do it a second time, and then he had to do it a third time actually before it worked. And we found the Portacat worked, and the factor got into his system. So it comes with a lot of emotional challenges. Even the fact of having to wake up earlier than a normal school kid to do an injection prior to school.
So this must be a challenge, I mean, both for the children and the parents. And how does it impact, adherence to treatment?
It is actually one of the important unmet needs in hemophilia, is that not only is the condition lifelong, but also to be able to be managed appropriately, you actually need to have techniques on how to get the missing protein into your system. Luckily, the scenario is changing in the sense that now we do have, to some extent, an evolving playing field where, intravenous access is not the only route. In fact, in our center now, a large number of individuals can give the factor subcutaneously. And that is actually a relief. We think that it is going to reduce the disease burden, but also the treatment burden associated with caring for people with hemophilia. And of course, the extreme, which is gene therapy, it's going to be just a once-off injection and no subsequent finding the vein or even subcutaneous injection. So some of us are extremely excited on this very evolving field of therapeutic modalities in hemophilia.
I was going to ask you about that research on that subcutaneous product, but perhaps we'll talk about that later. Let's take Colleen on the line from Pretoria. Colleen, welcome.
Hi, I wonder if you could help me. My mom was recently diagnosed with myelodysplasia.
Yeah.
And on numerous occasions, the doctor would want to discharge my mom and send her back to the frail care facility where she came from. And she's with the nosebleeds on a regular basis, say every 3 days, and she would get platelets and transfusions, and she would bleed tremendously. Now, what is the proactive treatment that we could give my mom?
All right. Thank you for the question. Acute myeloid dysplasia. Yeah.
Yeah. Just back to the basics that we referred to, that when you bleed is one of those three things, either the platelets or the blood vessel or the coagulation protein, which in this case is hemophilia. So Colin's mom is bleeding because in acute leukemia or myelodysplasia, the problem is the number of platelets are not enough. So that is the treatment of choice. In fact, she needs to have the replacement of the platelets in order to stop bleeding. It's different, obviously, from hemophilia, where you need to replace the coagulation protein in order to stop the bleeding. That is very, very important to be able to identify the underlying reason for the bleeding in order to institute the appropriate management. So I would suggest that you carry on with the platelet transfusions, because that is the most appropriate way to manage the bleeding in your mom, Colin.
All right. Okay, well, let me take this opportunity to thank you very much, Erica, and wish you all the best and all the love to your boy.
Thank you.
Going forward. Okay, well, time for another quick break. When we come back, we'll now wrap our discussion on hemophilia and looking at adults who've been living with hemophilia for a while. Please stay with us.
It's not about xenophobia.
There are many issues of service delivery, housing, illegal mushrooming of structures.
They are now starting to move to Sandton and to submit a memorandum.
You're not going with tires there. That's all. I will stop this march here.
When we're bending tires in the inner Alexandra, they kept quiet because now we are going where they report. That is why they are having a problem.
We feel really undermined and disrespected that he did not show up to listen to our grievances. He has grown a tendency of only serving the so-called white monopoly capital and has forgotten about black communities. Development must happen either or of all sides, because we are equally Batu.
But the people here today are saying service delivery to us, we deserve it.
The SABC News mobile app is your one-stop digital portal to all the news you need. Stay connected with the latest in breaking news. Watch the SABC News channel along with clips and live streams of all the big news events, and listen to all the SABC News radio stations live, including podcasts and much more. Simply download the SABC News app to your Android or iOS device from either the Play Store or the App Store. SABC News, independent, impartial.
Welcome back, and thank you so much for staying with us. We're discussing hemophilia with our guest, Prof. Johnny Mahlangu, clinical hematologist at Charlotte Maxeke Johannesburg Academic Hospital, Julie Malan, South African Hemophilia Foundation, and we're now joined by Andrew Chakumba, who's an adult living with hemophilia. Welcome to Health Talk, Andrew.
Welcome, sir. Thank you.
First, let's start with you to learn more about yourself. When were you diagnosed with hemophilia? How old were you then? Do you remember?
Yeah, I was diagnosed with hemophilia. I was around about 6 years old, towards 7 years.
Right.
I had a bleed on my right ankle, this one. I went to this other hospital and they were not aware what was happening and why am I having that bleed inside the joint.
Right.
So what they wanted to do an operation to investigate. So my mom refused, saying you can't operate on my son while you don't know, while you are not even sure what's happening with his ankle. So that's when I was transferred to Barra Hospital, and that's when I was diagnosed with hemophilia. That's when my mom became aware that I'm a hemophiliac. Yes.
Interesting story. I mean, the mom obviously was right about that, isn't that so?
Absolutely.
And secondly, the age of diagnosis, 6. Do you want to perhaps comment on that?
Yes, I mean, it just brings the conversation we had earlier on that the presentation is very variable depending on the level of the factor, but it also depends on other factors that we still don't understand. You do have individuals with factor level of less than 1% who you expect to bleed spontaneously, and they don't bleed, for example, the first 6 years. And in other instances, you've got people who bleed as expected with that low level of factor. So Henry's story is not actually unique. We see this quite often. Most of the patients that we look after are diagnosed quite late in life. And also, they can present atypically. The hallmark of hemophilia is to bleed into joints. So bleeding into the elbows, the ankles, and the knees is often the hallmark. So his presentation was not atypical, but sometimes patients do have an atypical presentation.
Okay, so Andrew, what did it mean to you then? I mean, you were 6 years old. You know, were you suddenly told you can't play with other boys or play what you used to enjoy before? What actually happened?
Yeah, there were those restrictions that I was informed of, that your life has to change now, and but being a kid, it's very difficult for you to understand that you have to change everything. You have to change how you play, how to do certain things. I mean, for a kid, it's very difficult to do those things. So I continued playing, continued to be a normal kid, continued to be the normal boy as every boy who was there around the location. So and that's what like continue being a kid. That's exactly what gave me to have more bleeds, like playing sports, playing soccer, running around, being a naughty boy at school, running on top of the tables, falling off, bleeds, and it was very difficult, especially being raised by a single mom who was not employed also. Like it raises frustration to her. Like I mean, each and every time when I had bleed, I mean, she would complain each and every time. I mean, why, you're not supposed to play like this, and exactly I don't have money to take you to hospital, and being told all those words, you end up even hiding your bleeds, and your mom will realize that you're having a bleed at a later stage, and when the swelling is already big, I mean, it will take you more time also to control the bleed, also for the swelling to go down more days and more factor also. And again, it was a distance again to travel from Sebokeng to Barra again. Yes.
So is there a time when you decided that, you know what, this is enough now, I need to now change?
Yes. There was a time also that I remember I was in grade 10. That's when I was also diagnosed with inhibitors. I was using factor before, and then after 2016, that's when I was diagnosed with 2010, diagnosed with inhibitors. So that's when I realized, this thing is serious, and I need to change how I enjoy life, how I play around, how I do certain things. I mean, this is my life, or at the end I'll end up being crippled. So I didn't want that, because that's when I get to see other hemophiliacs and how they were, crippled, and others, they couldn't even stretch their elbows, they couldn't do any most of the things they couldn't do because of the bleeds that they had on their joints. So
where are you in terms of, are you on any particular treatment?
Yes, I'm on prophylaxis, taking Novo 7. Each and every week, 6 milligram of that dose.
And how would you describe your life now? It's fairly normal?
I would say it's very normal because of I'm no longer experiencing the bleeds like I used to before. So my life has changed a lot.
Right, right. So essentially the message is that you're living a normal life, despite the fact that you have hemophilia.
Yes.
Let's talk about cost of treatment and access. You know, I mean, you said earlier that you help families, you know, take them to treatment centers and so on. In the clips that we played, the treatment can be quite expensive.
Yes, treatment is quite expensive. In the state setup, our state patients, they have access for free to the treatment.
Right.
But it may then sometimes mean that they don't have factor to take home, and then they will have on-demand treatment. Patients on medical aid, it is one of the PMBs, so we are fortunate that we get our factor at home and we can be on prophylaxis and then end up living a normal life like Andrew was saying. And that's what we at the South African Haemophilia Foundation would like for every patient. Because if we can prevent bleeds, we can have a whole generation of people with haemophilia growing up and living normal lives and not have joint issues. But yes, the cost is one of the problems that every person with haemophilia faces.
Prof, you mentioned earlier 21 treatment centers around the country. Are these mainly, one would guess that these are mainly situated in urban areas?
Not all of them. In fact, we differentiate between two types of treatment centers. Comprehensive treatment centers, which are associated with academic centers. We're talking here about Pretoria, Vets, UCT, KZN, Bloemfontein. And then ordinary treatment centers which are not necessarily in large urban areas. Kimberley, for example, Northwest, Mpumalanga, those will be just Port Elizabeth, East London. Those will be where the treatment centers are. The thinking is that we want to be able to allow patients to access the expertise and the necessary resources to be able to manage the hemophilia.
Yeah. Is it a condition that's only managed by the experts like yourselves? Or, I mean, what about the ordinary family practitioners out there that are, you know, the primary contactors?
It is a journey, and I think this is actually an example of us reaching out to our counterparts who are not experts so that they can be comfortable in managing the condition. If you look at the core of hemophilia treatment, it's actually a primary health care condition, except that, as you alluded to, is that the therapy associated with it is actually inaccessible to the patients. But the majority of the patients, for example, at Charlotte Maxeke, can inject themselves without an assistant of a specialist. And they can certainly do it on their own without an assistant of a general practitioner. So we see hemophilia care as crossing all the health care categories of care. But we want to move it, in fact, to the primary health care for the individuals that are well informed, that understand how it is managed, so that we can manage the
That's where we're going to have to leave it, unfortunately. We've run out of time, and thank you so much for all the valuable input that we've had so far. And thank you to you, Andrew, and Julie Malan, of course, and all the other guests that we had before. And to you at home, thank you so much for watching. We're back on your screens again next week, same time. I'm Dr. Salomut Daung. Until then, please do take care.